So I'm going to describe our experience at Sheba Medical Center with MR-guided focused ultrasound for bone metastases over the last few years. Sheba Medical Center is one of the largest hospitals in Israel. We have 1,800 beds, a university-affiliated tertiary referral center in the Tel Aviv metropolis. The Oncology Institute sees over 2,500 new patients a year. We have a large clinical trial center. We do in-house and collaborative phase 1, phase 2, and phase 3 studies. And just now, we're just inaugurating a dedicated phase 1 study, which is one of the few study centers run in cooperation with one of the major drug companies. As far as radiotherapy is concerned, we see over 2,000 new patients a year, and we do IMRT, IGRT, and all the modern technology. And we have a large brachytherapy suite. And the Translational Cancer Research Institute is attached to our institute. So we are the ideal place for forefront research in cancer treatment, and I see focused ultrasound as being another arm of the radiation oncology tools to treat cancer. The clinical work done at Sheba in the last few years initially was the uterine fibroids, adenomyosis, as you heard in Dr. Rabinovich's talk earlier. We did a small breast cancer study in the beginning of the last decade and a small breast tumor cancer study, but our main focus as far as cancer treatment is concerned is on bone treatments, and since early 2005 we've treated over 50 patients. Next. Okay. So this is a cartoon of the treatment. The patient lies in the machine where we put the pain. She lies with a painful area. The area to be treated lies on the transducer, which is one of the problems of setting up the patient because she has pain. But can we do that once more, please? So we position the patient with a painful area to be treated over the transducer, and the transducer can be moved and angled to be able to focus the ultrasound from several directions at the target. Next. Okay, so you've heard many talks about the benefits of MR-guided focused ultrasound in this meeting: non-invasive, no hospitalization, limited conscious sedation, which, in fact, these treatments of the bone can sometimes be very painful. And you'll hear in my colleague, Dr. Rabin's talk coming soon, that initially we try to give the sedation by the radiation oncologist. As Dr. Hurwitz mentioned, these patients are often very problematic. They're getting large doses of opiates before they come first to treatment, and it's very difficult to titrate the dose of pain sedation without giving too much or too little. And we have now incorporated anesthetist into our team in order to get the patient the maximal benefit of that. There is no radiation, and the patients can return to normal activity usually by the next day, and a very low rate of complications and reduced cost. We initially did an animal study, as you can see here. On the top left, the treatment day. On the right, you see the macropathology 3 weeks after treatment, showing a round lesion where the focus of the ultrasound had been. And below that, you see the MRI images. Below, on the bottom line, you see the MR image, the T1-weighted MR image before treatment on the left, and in the middle, 3 weeks after treatment, showing a lesion in exactly the place where we positioned it and the corresponding pathology. The MR-guided focused ultrasound system for bone metastases received the European CE mark in June 2007. Israeli regulatory approval was received in April 2008. We are FDA phase 1 studies completed, as Dr. Hurwitz mentioned, and we are accruing well in our phase 3 study. Hopefully, we should get approval sometime next year. The phase 1-2 study, which was mentioned earlier, so I'm just going to go through the inclusion and exclusion criteria once more. Patients over 18, painful metastatic bone lesions, less than 8 centimeters in size, or following failed radiation therapy or not amenable to other therapy. Exclusions were impending fracture, multiple metastases, or when the tumor is too close to the skin or the spine, and we were worried that the heat would cause side effects, either burn or neurological damage. And again, skull or bearing wounds weren't included. And our patients had to have a life expectancy of at least 6 months. And the endpoint was a 2-point drop in the VAS pain score or reduction in medication and a low complication rate. I think you saw this slide before. In Sheba, we treated 35 patients with 33 lesions. There were no significant device-related adverse events. 1 patient failed to tolerate treatment and stopped treatment because of pain during treatment. 69, the pain success, defined as a reduction of 2 points in the pain score, was 69% after 1 month and 79% after 3 months respectively. And if you see in the pie chart, you can see that more than 1/3 of patients had complete pain relief and more than another 1/3 had partial response to treatment. If you look at all the series and the meta-analysis of radiotherapy for bone pain, the response rate overall, complete and partial response, using similar criteria, is about 2/3. So we're certainly well up with then, particularly if we take into consideration that almost all these patients had prior radiotherapy, so they're getting this focus also on a second-line treatment. You can see the average pain score in the chart on the right, showing that we usually saw significant pain relief within days after the treatment. I'll just give you a few examples of patients treated on these studies. This is a 44-year-old woman, primary breast cancer, which had targeted the lesion in the left iliac bone adjacent to the iliosacral joint. She received 34 sonications to cover the target. It was a 1-hour procedure duration, and you can see her pain score reduced significantly and went down to 1 within 2 weeks. Another patient is a 70-year-old prostate cancer patient, again with iliac metastases, and pelvic bones are the most common site we are treating. Total 26 sonications, 48 minutes procedure duration. Pain disappeared completely within 3 days of treatment. Another case is a lung cancer patient. He had 3 painful lesions, one in the right iliac bone with a pain score of 8.5, a spinal lesion of 6.5, which obviously we didn't treat, and a scapular lesion. And according to this protocol, we treated the most painful lesion, and that is what was treated. And again, you can see the lesion on the MRI. The patient was positioned supine with a bit tilt to the right so that he was lying on so that the lesion was lying on the transducer. 25 sonications were performed. The energy range is here. We observed very good temperatures with our real-time temperature feedback from the system, which has been described earlier. The patient spent just over 2 hours on the table, and the sonication time was 72 minutes. As you can see from the pictures at the bottom, you can see the treatment directly on the lesion, and the heat and the temperature charts on the right showing the temperature reached in the target, whereas outside the target, we avoid reaching high temperatures. This is a post-treatment MRI showing the area. Let's see if I can. Here you can see the area which had been treated now does not enhance with contrast. This is soon after the treatment. And this is another case, another patient treated just over a year ago, a 43-year-old female patient, primary breast cancer, with an osteolytic metastasis in the left iliac bone close to the sacroiliac joint. Again, position was supine with feet first. And you can see here the lesion which we treated. Here's the sonication. She required 29 sonications. Very good, again, good temperatures observed. And one of the things we began to see in these patients, we saw we got a good temperature in the whole tumor, and we began to ask ourselves, what is the mechanism of our pain control in these patients? We originally thought we were just treating the periosteum to heat the nerve endings, but maybe we're also getting some tumor control from our treatments as well. And as Dr. Hurwitz mentioned, today, with improving systemic therapies for cancer, some of our breast cancer patients with bone metastases may survive 5 or 10 years after they present with painful bone metastases. We see the same with prostate cancer, and we begin to see the same thing with other tumors. So maybe it's important not just to treat the pain, but to see if our MR-guided focused ultrasound treatments will also control the local cancer. And for some tumors, like thyroid cancer and sarcomas which are relatively resistant to radiotherapy, this may eventually turn out to be a very good alternative for these patients and give them long-term control. So you see in this patient the tumor control over here, not enhancing. And this is at 3 months. Again, we see this long-term tumor control from the treatment. Overall, the average pain score of all the patients treated at Sheba started with an average pain score of 6.9, reduced to 3.6. And as Dr. Hurwitz mentioned, we've now started using, in addition, a new conformal bone system. This has the advantage that the transducer can be placed on the painful lesion. So instead of positioning the patient, which is often very painful, so that his lesion lies on the transducer in the treatment couch, the patient can lie comfortably, and we just place the transducer over the lesion. We've treated 11 patients who have received 13 treatments, and this is the system here. This is the coil. This is the couch the patient lies on. And these are several sites which have been treated. There's a patient with a lesion in the thigh, so he could lie on his back instead of on his abdomen and get treated to this lesion. There's a humeral lesion, and humerus and head of glenoid, which could be treated with the conformal bone system. An example of a treatment result. This is a 50-year-old patient with metastatic colon cancer. He had an osteoblastic lesion in the left iliac bone, 19 sonications, 95-minute sonication time, and you can see here the response. He's lying here on his abdomen, and this is the target. You can see here the response. His worst pain went down from 8 to 2, and his average pain score after 1 month is down to 1. So a very good clinical response for this patient. We have several ongoing studies at the moment. Dr. Hurwitz mentioned the phase 3 randomized study where the patients are randomized versus a sham treatment. An important point in this study is that patients who don't respond to the sham arm have the option to receive actual true treatment 2 weeks later. So ethically, we feel very safe offering these patients protocol, because eventually, if they need it, they will get the real treatment. We have a study looking at the conformal bone system, and we've recently started a new study up front for patients with no prior radiation, where the randomization is between MR-guided focused ultrasound versus external beam radiation. And in this study, we've added on a new endpoint of long-term 6-month tumor control seen by MRI to look at this point that I mentioned earlier, that maybe we're getting better tumor control than we would get with radiation therapy. We have produced several publications, and I use this slide to thank all our colleagues who took part in these studies in the past. It's a team effort, so we need particularly the radiology department in Sheba, Dr. Imbar, who's here representing them, the orthopedic surgeon, Dr. Lieberman, and our colleagues in all the other hospitals who've been working with us, and last but not least, our people at Insight Tech who gave much support for these studies. Thank you.
We have time for 1 or 2 brief questions.
Okay, there's one.
I'll pose a question. With the new conformal device, I know you showed a pelvic treatment, but are you finding that you're using it to treat a wider range of sites than you could with the table-mounted device?
I think not many more. I think that most of the patients who are treated now with the new device would have been treated with the other device, but much more difficulty. There are 1 or 2 patients who we couldn't treat, and this is allowing us to treat them.
It's allowing you quicker setup on those patients.
It's much more comfortable for the patient. I mean, this is palliation. We want to make the patient as comfortable as possible. There's a question on the board. What do you aim for? Lesion, periosteum? What is the mechanism of action? Well, I think I partly answered the question, and the question is to both of us. Initially, we were aiming for the periosteum. We believed that we were pain control by destroying the nerve endings. Because of patients like the one that I showed you, where we see control of the tumor as well, we are now investigating that maybe it's also an effective way to control the tumor as well as pain control. You want to?